Okay, so we are now recording. So this is a podcast that my friend and colleague Alan Mathew, who is a lecturer in occupational therapy at the University of Salford, has kindly said that he'll do for us. This was recorded on the 3rd of March 2023, and Alan's going to talk for about an hour about the topic of social prescribing. And I've just come up with some questions that I thought were the kind of questions that undergraduates might want to ask. And then the hope is that we can, with Alan's permission, put this out as a proper podcast that we can put on, obviously for the university in a wider sense, and maybe social media as well if it works out okay. So, Alan, thank you for doing this. I am grateful. I know I'll give you a hard time, but I do appreciate you. Do you want to just introduce yourself first of all, Alan, to the audience? Because it's probably going to be mostly physios in the first instance, and they may not know you. Can you tell us a bit about yourself first of all?
Sure. So my name's Alan Mathew. I do work here at the University of Salford as one of the lecturers in the Occupational Therapy department. I guess the best way to kind of introduce myself is that uh, I tend to have my interests kind of gathered across a range of different areas, but one of the areas is social prescribing. And actually, I am a member of the Salford Social Prescribing Hub, which has been working out at Salford for the last few years. I'm My capacity within the hub is more realistically as a lead trainer, but I tend to work quite closely with link workers and social prescribers in the GM and wider network areas. So it gives me a bit of an insight into what social prescribing is. So I'm hoping to just give people a good introduction to what social prescribing is today.
Okay, thank you, Alan. Alan also works as I do in admissions, so we've kind of got a shared pain there. We've got something in common as well. So the first question that I wanted to ask Alan, and this is a kind of a genuine question because I don't profess to know much about social prescribing. It's a relatively new phenomenon to me. So first of all, can you explain what social prescribing is, Alan, please?
Yeah, sure. So social prescribing, in order to kind of truly understand it, that there's much wider explanation to it. But fundamentally, social prescribing is about connecting people to activities that are largely meaningful to them to help them maintain their physical, mental, and social health. Really, in order to kind of understand that, we need to consider things wider from a point of view of how people perceive their health. So when we talk about health, we're quite quick to consider physical health as an aspect of how we measure health, or we consider our mental health as part of how we measure our overall health. But actually, there are wider social factors that impact the way in which, or affect the way in which, we perceive our health. Part of how social prescribing comes about is because social prescribing isn't a new concept. So the way in which social prescribing works has been going on for a significant amount of time, and you could probably trace it right back to the 1990s. It had quite a bit of success in the early 2000s, but more recently, it's come into the public domain as of about 2017 to 2019 because of the personalized care plan, and then the long-term plan that came after that as well. So realistically, what's happened, in order to kind of give you guys a background as to where social prescribing comes into the public domain, is that we have moved away from a much more medical model way of thinking about health over the last kind of 15, 20 years, and thinking about how we can support people to manage their own health within their own environments, really. Because if we really think about how much we access health services, we tend to spend very little time actually in contact with, say, a GP or a nurse practitioner or primary care services, or accessing secondary or tertiary services. And a lot of the time, people who have long-term illness, injury, impairment conditions, whatever you want to label it as, tend to actually self-manage that within their own environment. So social prescribing is really looking at how health can be managed through the use of meaningful activity, but outside of the medicalized environment.
Thank you. That's a really detailed, comprehensive answer. You may have actually answered my next question already, but I'm going to ask it anyway. So the next
Yeah.
question is, why do we need it? What was the driver that required this to come into being, really?
So, as I mentioned, with the long-term care plan, it's essentially about giving people the choice of how they manage their own health and well-being, but also from a wider point of view, is giving people control of their health and well-being again. I think there is a wider perception that health must be managed by a healthcare professional, but actually, fundamentally, say for example, sure, I'm going to pick on you now for a second, but say if you were feeling quite unwell, and someone came along and said, actually, you're not that unwell, you can do this and that. Who are you more likely to listen to? Are you likely to listen to yourself, or that healthcare professional? So it's about balancing that choice for someone, being giving people more autonomy over their health, but fundamentally also kind of reducing that power gap between healthcare professional and person managing their own health in that prospect as well. In terms of why we need it, it fundamentally comes down to the fact that people are going to need to manage their own health. I mean, fundamentally, the health services are quite stretched significantly, and there are barriers to what commissions are put in place in terms of what service provision there is. So, getting people to be having people supporting themselves out in the community, uh, but also within their own particular environments and the things that they do, can have long-term benefit in terms of physical, mental, and social health.
Okay, excellent. Thank you. It's interesting you talk about a power differential there, because it's something that we as physios are probably not good at recognizing, but getting better. So certainly when I think about my career, the thousands of hours that I've spent telling people what to do, or giving people exercises on a sheet of paper that in my own arrogance I assumed that they would do and that they probably didn't do. It's probably, you've hit it on the head, I think, there. So that's excellent. Just talk to me a little bit, Alan, about how it really differs from what the old status quo was. And again, you probably kind of answered this medical model. Just talk to the audience, because they may not know what you mean by the medical model. Can you just flesh that out for us?
Yeah, of course, of course. So, I guess the best way to describe it is that there are parts of healthcare that are very deficit focused. So some might say that when we think about health and well-being, we often tend to kind of label people as part of what condition they have. So, say for example, calling someone, say for example, if someone comes to your service as a stroke patient, you refer to them as a stroke patient. But actually, that person is a multifaceted being. So there'll be a certain age, there'll be a certain ethnicity, part of a certain culture. They'll have a certain sexuality, they'll have a certain gender, and all those factors, religion, a range of different factors that make them who they are. And I suppose it really goes back to what I was talking about in terms of how people perceive health and well-being and how they describe it, because depending on the literature you read, so the World Health Organization, way back in 1946, said that health and well-being is defined as the absence of disease or illness or other infirmities that kind of stop people from functioning. But actually, that's a very outdated way of looking at what health means, because when we consider what health means in different cultures, for some people, health uh, can mean that absence of illness or injury, but it can also be social health, how they perceive themselves in terms of their place in society, how they deem their social interactions and the people around them. So health has a very it has a very broad definition across, but in terms of where that ties in into healthcare, uh, I do think that historically uh, we've considered, or rather, services have considered health to be very much deficit focused. So, what is this person's problem in terms of what issues are they presenting with? How can we fix it? Whereas much more recently, what I've noticed across the different healthcare professions is a lot more of a holistic focus. So people are being considered from a much more um, less of a less of a bottom up approach and more of a top down approach, and
Yeah,
in the sense of considering the wider factors that are affecting someone and then kind of leaning more towards the specifics. And I'm sure that will be reflected across in physio in terms of P&O, diagnostic radiography, nursing, a wide range of different AHP professions.
yeah,
But the way in which we consider it is slightly nuanced depending on what part of the profession you're in. And what I was referring to earlier when I was mentioning the power situation is that we as healthcare professionals believe we know what's best for a person based on our experience, our perceived expertise, but it doesn't necessarily always marry up with what that individual feels is best for them or is looking at in terms of their unique and perceived need.
yeah, yeah. That's
Yeah,
really interesting. Just while you were talking, I was just thinking about how that relates to my recent past. And as you know, I've recently had a bereavement. My mother passed away about a month ago, unfortunately. And when it comes to things like that, the things that you value are, she was in a care home, and you value the things like you've just been talking about, the fact that they don't see her as a lady with early dementia. They see her as Winifred, who likes to do crosswords, who likes to talk about the TV, who likes to watch Bob Ross on TV. And it really hits home when it's a relative. It
mm,
really makes, it's a sobering thing, isn't it? It makes you realize that it's not the stroke in room 5. And when you were saying that, I was kind of feeling guilty because I'll admit, I don't know about you, Alan, but I've worked in orthopedics, and the number of times I must have said to a colleague, I'm going to see the back pain in bay 5, or I'm going to see the knee replacement in bay 3. I'll admit I've done that. And there's no malice in that. There's no there's no ill will in that. It's just a way that I compartmentalize people for my own benefit. And yeah, it's not good. I would hate to think that I referred to a friend or a relative as the knee replacement in Bay 5 kind of thing. Just I'm going to be devil's advocate here, Alan. You're going to hate
sure.
me for this, but see how you respond to this.
Yeah,
Is
yeah,
there
of
an
course.
occasion where the therapist does know best?
I mean, of course. I mean, ultimately, what it comes down to is when people come to your services or they're referred to your services, they are someone coming to you in a time of need, and of course, there are times where you will know how to manage someone in terms of supporting them or helping them achieve what it is that they want to achieve. I'm talking about, I guess, the wider factors in terms of, um, I think as a allied health professional, I think it's our position to offer people our understanding, our expertise around a certain area and give them the best advice towards it. But fundamentally, consent comes down to the fact that they have to agree to it.
Yeah,
They have to agree to go through the process, don't they? So of
yeah,
course, there is a
yeah,
line to what I believe is right to be listened to. I guess it's about minimizing that dynamic as much as possible when we are working with people, because when we're saying that we're working with someone collaboratively, more often than not, we're not. We're telling people what to do, and they're
Yeah.
deciding whether they're going to go along with it or not. But
Yeah.
that's truly where kind of that relationship comes in, and I do think that social prescribing can help with that building trust and kind of building those relationships, but from a much wider point of view. But we're going to come on to that a little bit further on, I think.
Okay. Yeah.
Yeah,
I always think that you might agree, you might not. I always think that the best physiotherapists and probably the best therapists generally are the ones that can be a chameleon and know how to adapt and know when to let the patient lead and when to lead the patient. And that's a skill, isn't it? Some patients
yeah,
want to be told what to do. Some patients need to be told what to do, and some patients need a sit down, heavy discussion about what do you want to do. So that takes skill. I think students struggle with that sometimes, don't they? That can be difficult. Okay, let's move on to the next one. I have
sure.
to ask this, but what is the?
Yeah,
And I realise that this is a fairly new thing.
yeah.
What's the evidence that it's working, Alan? Is there any research out there
Okay.
that says yes, this is working?
So the evidence base is something that is quite difficult, mainly because of how social prescribing is placed at the moment. So social prescribing, I'm going to have to give you some context in order to really kind of understand this answer. So
Okay,
social prescribing at this moment in time is spread across a range of sectors. So a majority of it is spread across the third sector, or what we call the third sector, which means the voluntary sector more than anything. Um, so it relies on public funding, doesn't have a huge amount of profit, usually is quite under resourced. You do then have some primary care networks, so your GPs and different health catchment areas that hire social prescribers, which then has a certain amount of funding for it, but tends to be oversubscribed significantly, which we'll come on to when we talk about limitations or the critique of social prescribing, and then that factors into it as well. And then social
okay,
prescribing in its other form comes across in little private companies that work across. Now, the difficulty with establishing an evidence base here is that not all social prescribers work in the same remit. So there is a real lack of consistency in terms of the defined role of what social prescribing is and what actually differentiates social prescribing with a company that runs groups. There's also some problems in the way that social prescribers don't always call themselves social prescribers, so they have a range of different names. So they could be community connectors, community navigators, social prescribers, link workers. The list is endless as to the actual title that people work towards. So
okay.
main there's three main reasons why the evidence base is problematic at this moment in time. The first being that in order to there's not really a robust study of social prescribing at the moment because a lot of these services tend to be quite localized. So it's local to a very specific environment. So that means that the wider generalizability, the practicalities of looking at services between one service and the next service and the next service can be quite difficult. Um, I think in terms of from a methodological point of view, it can be quite difficult to kind of examine social prescribing across a wide area. And then, like I said, the generalizability of the research can be quite difficult because of what kind of work that each of those catchment areas do.
Yeah, I suppose also the question is where would you publish it? So if we don't quite, if it's not as standardized as you've suggested, I would imagine that different professions would go for different outlets for publication. Is there a kind of clinical interest group or special interest group, or is there a central body that's kind of trying to pull things together, or is it still kind of piecemeal, Alan?
So at the moment, it's a little bit. So there are networks. So across the UK, there are social prescribing networks that are kind of working towards that, and there's national steers for it. So there are people out there that are working towards combining them. And in the GM area, there is very much a huge social prescribing network that looks at bringing everyone together. Um, in fact, myself and my colleague Rowan Morris, we tend to do quite a lot of work with the link workers in those networks to kind of look at action learning sets and providing supervision and things like that. But um, in terms of whether there's interest for it, what's quite interesting is that the different allied health professions uh, lean into social prescribing, and different professions have different takes on it. So, say for example, the CSP, they talk about. So, if you look at I can't remember what the exact document is called, but if you look at some of the information released by the CSB around social prescribing, they support the use of social prescribing as part of practice,
Yeah.
and say that there is agency that all physiotherapists must be able to have an awareness of where social prescribing works within their particular area of work and be able to refer to them. Occupational therapy actually has quite a strong shared philosophical base with social prescribing, because fundamentally both of us, as in occupational therapy and social prescribing, focus on activity as a medium. There are differences between the two professions in terms of what it is that we're kind of thinking about, or what it is that we're focused on, but the medium in which we use is the same. Similarly, I was teaching on prosthetics and orthotics yesterday, and I guess their supporting body, I think it's called BAPO, says that they have to be able to refer to agencies to support people in line with social prescribing. So
Okay.
it's supported across professional bodies. It's supported within social prescribing with the wider networks, but um, there is still some wider work that needs to be done in terms of unifying all those different areas, if that makes
Okay.
sense.
No, that's great. Going back to real basics, I'm trying to ask a question that I would have asked as a student, and that I think
Sure.
a lot of my students would want to know. Could you give an example of, because students are going to still say, yeah, but I don't know what it is. I don't know what social prescribing means. Because if you
Sure.
say prescribing or prescription to a physio, they're going to assume exercise. Okay.
Right.
And if you say
Okay.
if you say social, they're going to assume a group work or a group activity or a class. Could you give us one, however simple example of what a provision of a social prescription would be, Alan? I've thrown that at you.
Sure.
That wasn't one of our original questions, but I thought it. Yeah.
That's fine. So, social prescribing then. Okay, so examples of social prescribing. In fact, I think I will give you a bit of an overview of what might happen. If, say, for example, one of our students here, or someone was referred by their GP, a healthcare professional, or wider to a social prescription service, here's what would happen. Okay, so what would happen is you'd be referred on someone who works within social prescribing. So community navigator would get in touch, or a link worker would get in touch. They would have a conversation with you around how you perceive your health and well-being, what kind of things you like doing, and they try and get to understand what it is that you are interested in doing from a non-medicalized point of view. So the prescribing is a bit of a misnomer. What it really means is that this person would then go away, they would look at their arsenal of resources, that they have that they have access to. So they'd look at what resources they have in terms of what groups are available to this person in this particular area to help support them or help engage them socially or help them maintain their physical health. Sometimes, so what that could mean is that could come in the form of a gardening group or a social group, or might be based around a specific activity like chess, or it might be a crafting group of some kind. Now, not everyone will be looking at group interventions, because, same as with people, you have your introverts, you have your extroverts, you have your people who don't necessarily get a lot of community engagement, in which case the social prescriber would work with them in terms of finding things that they want to do that's meaningful to them to help boost their health as well. Now, in
Okay.
some places and in some businesses, social could help people in terms of job hunting, or helping them in terms of managing their money, or seeking out support with um, social housing or wider factors like that. Does that make it clear, or have I
That's
kind of
great. Yeah, that's
complicated it a
great.
bit
So,
more?
yeah, I just felt it was important because, as you know, I most of my teaching is with first years who are very bright but will not have come across this before at all, and they will literally
Mm.
not know what it means. So I just felt that that was great. That was just as an example of what it might look like. So it really is holistic, isn't it? If you're talking about kind of financial advice to gardening to chess, that really is holistic patient management, isn't it? That's excellent. Thank you. Okay, so the next question is, um, where do you see it going, Alan? Where do you see it in the next 5, 10 years?
So I do think that social prescribing is going through a interesting position at the moment. So the long-term care plan wanted, I think it was like a significant, it was a huge number in the hundred thousands. I can't remember what hundred thousands it was, that they wanted people connected with social prescribing by the year 2023, 2024. So we're kind of getting to the end of one long-term plan at this moment in
Yeah.
time. So politically speaking, we're at the brink of changes that are coming in. I think if social prescribing can truly be harnessed by healthcare professionals and also social prescribers, I think it could change the face of how we perceive health within this country and the actions we take towards supporting people in maintaining their health and well-being. So if I was to clarify that a little bit further, um, so say for example, one of the biggest kind of uh, detriments to the success of social prescribing at this moment in time is the lack of communications between agencies. So we
Yeah.
have healthcare professionals who are working within their remit, but obviously restricted by their the commission that their service provides. And then you have a gap in the service, and then you have where social prescribing operates on the opposite side, but they also have uh, a gap and a barrier in terms of their scope of practice as well. And
Okay.
reducing that gap between the two groups, I think will be something that if we can reduce that gap, I think that is something that would help boost the use of social prescribing in the future. And I certainly do think that in the next 5 to 10 years, as we evolve our understanding of health and well-being, that could play a huge changing role in the way in which we manage our health and well-being in this country.
Okay, excellent. So the next part I want to come on to is limitations. But before I do,
Sure.
just to give the readers or the listeners rather some context, this podcast was recorded at the early in spring 2023. So we're in the coming out of a major pandemic time. Staff in the NHS are going on strike. It's the NHS is on the news every day, underfunded, chronically underfunded, not coping. Um, that's the kind of context that we're in at the moment. So my question to Alan is, what are the limitations um, or restricting factors, I suppose, to making it work?
So one of the restricting factors, and I think COVID is a really good example, is that we have um, people who have been, I mean, the situation is that COVID caused a lot of harm in wider ways than just the virus. There are people who struggled in terms of their health provision over the last few years whilst we were in lockdown and coming out of it. There are people who are still struggling because of a range of effects that came past that. And you're right in saying that the healthcare services, they were stretched, and there are healthcare professionals who are burning out or experiencing PTSD or wider factors from what had to happen during the pandemic, and that has a profound effect on social prescribing as well, because the need for these services are rising as well. The limitations that come from that is that at this moment in time, there are people out there that have wider complexities, and in managing those complexities, social prescribing groups and services are being used as a bit of a plaster seal or a battering ram. So, people, they're getting loads and loads of referrals in order to support people. However, sometimes these referrals are for things that are outside of the profession's scope because of the increased complexity. Uh, and like I was saying before, um, when it comes to the fact that there isn't a standardization as to what role that social prescribers play across, or what roles that social prescribers commit to across different services, there's a difficulty because the expectation is also very different across services. So when people are referred to and they have wider complexity, sometimes these social prescribers can come in from really, really different backgrounds or different and creative backgrounds, and they might not have uh, the kind of the skill base that requires that complex need. They're able to support that person, but actually, if there's a complex need behind that that's then causing the root issue, they're not able to work with that. So at the moment, one of the limitations is that it's being abused to a certain extent because people are trying to use it as a magical bullet when it's not. And some of the limitations are it's a double-edged sword. So some of the limitations come from the field not being able to kind of unify a bit of a definition as to where the scope is, but also from what's happening in terms of the abuse that these services have in the way of how and who they're working with. Does
Yeah.
that make sense?
Yeah, it does. It does. Yeah, yeah, it does. Okay, thank you. So the final part of the podcast that I wanted to talk to you about was as an educator, as a lecturer, if I were to become a occupational therapy student next year, how
Sure.
soon would I be exposed to social prescribing? Would it be a one-off lecture? Is it threaded throughout your program? Is it drip fed throughout the whole year, 3 years? Is it a thing for placement? How do you get this across to your students?
Okay, so in terms of how we get this across to our students, we tend to it is a bit of a wider approach that we take. So we certainly have a lot of discussions around health and well-being and activity in first year. That kind of leads into our how we think about the way in which we explore health and well-being, and certainly that becomes much more critical in second year. In terms of where we kind of introduce them to social prescribing, I guess that's really more around kind of the critical elements. So probably level 5 and up, where we start thinking about how that comes across in our relationship between the professions, but also in terms of recognizing where other professions might be working across similar philosophies. So certainly in our role emerging placement that we have with our OT students, some of the role emerging placements have a real link in with social prescribers and social prescribing, and we've often had students join us in the social prescribing hub as well to work on and understand where social prescribing falls under that. There are wider things that we signpost our students to, so we do try and connect them with the networks and connect them in with the wider CPD that looks at kind of involving them in understanding where social prescribing comes in. I guess really in terms of where that kind of falls, I guess the wider question here, I assume, Stuart, is where that falls, why it's important for our students to know about social
Yeah,
prescribing, is it? Yeah, I think it's
yeah, yeah,
important because I think going forward in terms of healthcare in the future, I think the way in which we perceive our health and well-being will change. I mean, just how much it's changed in the last 20 years is an indicator as to how much more it's going to change in the next 10,
yeah,
15, 20 years.
yeah,
The reason why our students need an awareness is because as that growth and development of our understanding of health and well-being changes, they're going to have to also cater and manage that kind of growing need within their own practice as well. So when we come, say for example, with the physio students, it might be the case that they might come across someone who they're working with that actually, yes, they have a physiotherapy need and a reason to be there, but actually there are wider factors that are affecting their participation or their engagement in that particular treatment, or there are restrictions that stop them from really getting the most out of that input. Having an awareness of what services are around, or having a good understanding of uh, or having links in with local communities can really help reduce that gap. And it might be
yeah,
the case that there's a lot of collaborative working in the future, or it might be a
yeah,
case that it needs to be influenced with their thoughts. So, really, it's about making sure that the practitioners that come out of here and the future really are people that have that awareness that actually there's got to be a lot more reflexivity in practice.
yeah. No, it's interesting. Again, while you were talking, I was trying to think about our program and how good we were at doing this. I don't think we package it very well. I don't think we badge it as social prescribing, but I think we're starting to acknowledge it. So, for example, a lot of the exams that our students do are practical Viva examinations, and we'll quite often give them 4 different scenarios 6 weeks or 8 weeks before an exam, which contains a lot of social information, a lot of social history, family history, whatever. And I think we do this, but not as well as you guys. I think we do encourage the students to think outside the box. We encourage them to think about going to a chess club, going to see another health professional, but we've never, I certainly have never really badged that as social prescribing. So I think we do it to a degree, but probably don't flag it as we should. We've always tried to encourage students to think about the person as a whole, not just the back pain or the hip replacement. And I think students do that, but I think you're trying to take it to the next level, aren't you? Really? Um, do
I
you
guess
find
it's
that? Sorry, go on.
No, I was just going to say, I guess I think it's almost important to consider social prescribing as less as I know that I know the description is about connecting and referring people to wider services. That's the fundamental part of social prescribing. But um, I think it's almost helpful to take that one step further and kind of think about social prescribing as a wider concept than just that prescriptive role, or that specific action of this is what we're doing. And I think that makes it a lot easier for people to digest and understand when you do take that step back, if that makes sense.
Yeah, it does. Yeah. Do you find that with your students you get good buy-in? Do they get it?
Yes, I think that that's actually quite a political question, actually, because within the field of occupational therapy, now this occupational therapy is no different in terms of, every profession has their sticking points, don't they? There are occupational therapists who believe
Alan,
that
can I just say, as a physiotherapist, we don't have sticking points.
that's an absolute lie,
We do.
and you know
We
it,
do.
I know it. It's come on. Uh, I've worked with physiotherapists long enough to know that that's an absolute
Okay.
lie. Stop it.
Okay.
Right, right. But as in every profession, there are sticking points, and um, particularly within the field of occupational therapy, there are occupational therapists who, for lack of better words, believe that social prescribing is invading the professional territory, whilst
Mm,
there are other occupational therapists who believe that actually this is really good and that actually having the opportunity to uplift and support a profession that actually embodies some of the same values, the philosophies, would be amazing. So it is a little bit contentious
yeah.
within the occupational therapy profession, and we really try and work hard with our students to give them a bit more of a balanced view as to why. Um, so the buy-in tends to be according to how strongly the students take in terms of that position. I personally, um, I personally do kind of fit somewhere in the middle around that because I absolutely see the benefits that social prescribing has. Um, but I also think that the profession of occupational therapy could be a little bit better in terms of defining why they feel like they have such a strong hold over meaningful
Yeah.
activity or occupations. But I don't know where that might translate across into different professions.
Yeah. It's interesting. I get exactly what you're saying. You're always going to get that tension between being a professional X and being a team player, aren't you? You're always going to have that. And
Mm,
I don't know, certainly over the last, I've been in this game a long time now, and certainly I've seen a change in the students. It used to be that the students, for example, on placement, would kind of pull their nose up at being part of a very closely knitted team, but now they get it, they thrive on that, and they enjoy that. So I don't know. I suppose as things take time to change, don't they? You're not going to change the professional mindset overnight, nor should you want to. But I suppose it's going to be a gradual osmosis of change and mutation to a new thing, isn't it? Really? Um,
absolutely.
yeah. So we only badge one session that I'm aware of, which is this on social prescribing, which is a start. Um, I suppose the question now is how should we follow it through to higher levels, and should we be including it in master's programs? And I would imagine that in the future you're going to see PhDs in physio, OT, whatever, wanting to look at this area and that give it some more gravitas, I
The-
suppose. Increase the research base in it. Final question, Alan. If
Oh,
students want to know more about
oh,
social prescribe, sorry, go on.
no, no, finish your question because I think it might feed into it.
Okay, I was just going to say, if students want to know more about social prescribing,
Mm.
where would we be directing them?
Okay, so to just answer your statement and the question, there's already people working on PhDs around social prescribing within our professions of OT, physio, etc.,
Okay,
etc. So there are people already looking at PhDs around the specific area and their wider interests.
okay.
I in order so if our students listening to this right now would like to understand more about social prescribing, there is the oh I'm gonna have to I don't want to get
So,
the
if you like, Al, at the end of this, I can when I've made this into a podcast, I can put some slides up at the end for you if you like.
so there is the National Social Prescribing Network. There is the National Academy for Social Prescribing, or referred to
Okay.
as NASP. that people can look at. There's the KTP, so that's now you're trying me. The KTP, it stands for uh, hang on. I
Okay.
always forget to look at the full form. It's the
I kind of threw that question at you without any rehearsal, so
yeah.
it's
Thank
it's
you
not your fault.
for
Okay.
that. Let's the knowledge transfer partnership. So
Okay.
that's well worth looking into. There are kind of more kind of nationalized versions of where people can find more information about social prescribing, but I actually think that another way in which that people can engage within social prescribing is to look at what CPD opportunities there are about around social prescribing, getting onto social media, looking at Twitter. There are companies like Elemental that really kind of look at kind of demonstrating what social prescribing looks like in their kind of digital arena. It's well worth getting students to explore the literature, the critique around social prescribing, especially in the specific area. And if you look back to your own professional bodies, uh, I think CSB has definitely published something very specifically about social prescribing that they want people to look at a little bit
Okay.
further as well. So there are multiple avenues that students can explore. What I
Okay.
think would help influence their learning further is to start maybe considering when they go out on placement or when they eventually get out into practice, looking at what local links and communities their service actually has, and looking at establishing that relationship very, very early on. And I think that's going to be the best thing that supports their learning around social prescribing.
Final question, Alan. What was your first introduction to social prescribing? How did you first become aware of it?
How did I first become aware of it? Right, so
Yeah.
Um, so I had some kind of pre-existing knowledge. So back in my practice days, just before I moved up north, in fact, about a year or so before I moved up north, I heard about these voluntary sector services that were starting to work around in terms of supporting people once they'd kind of come back home out of hospital. And this
Okay.
it wasn't like a friendly support service or anything like that. It was a service that looked at very specific and kind of very unique things like going out to do something or linking in people with specific types of activities. So I had
Okay.
kind of like a brief understanding that there was something going on, um, but it was really moving up here and coming into Salford. Uh, Two of my colleagues had wanted me to come in to the hub in order to work with them on creating a tool to support social prescribers in navigating the process of working with people, and some of the
Okay.
wider things around training link workers. So that's how I got introduced to it. But I have to say, the more time I've spent looking at social prescribing and the more time I've spent discussing it, the more I'm sold on it. And the
Yeah.
more and that's not necessarily because I've only come across people that have been overtly positive about social prescribing. I've had many a critical discussion around social prescribing and the positives and the constructive feedback around it. And the more
Okay.
time I spend with it, the more I think it is the future.
Good. Good. Thank you so much, Alan. That's excellent. Thank you for your time. Um,
Right.
Guys, what I'm going to do with Alan's permission is make this into a motion picture. Alan the movie, we're going to call it.
Oh
I'm
God.
gonna, I'm gonna, we've got a book deal in the way as well. No, I'm gonna make it hopefully into a formal podcast that Alan can use for his students and we can use for my students and other students in the university arena as well. I'm very grateful for Alan for giving us some insight into this topic. It's not something that I know as much as I should about. Alan did this lecture last year, so that was my first introduction to it, but I'm hoping that it will only go from strength to strength. And if you do have any questions, I'll try and get some more formal links at the end of the final video that you guys can have a look at. But thank you very much for your time, Alan, and I'm going to
No, thank
stop
you. Thank you.
recording now.
Thank you for having me.